Welcome to the deep dive. Today, we are really strapping in for a fundamental look at the brain. Not
Mhm.
just how it functions when everything's going right, but, how it breaks down, sometimes catastrophically.
Yeah, whether that's slowly, over decades, or bam,
Mhm.
instantly in a crisis.
Exactly. And when we talk about cognition, it's broader than just thinking, isn't it?
Absolutely. It's really the whole comprehensive system, how you take every sensory input, sight, sound, touch, smell, and turn it into, well, usable information.
It's the engine, basically, for memory, decisions, your whole interaction with the world.
Precisely. It's the core of how we operate.
So our mission today is to take this stack of sources you've shared, really great material, by the way, and just pull out the clearest possible picture of what happens when that engine starts to fail.
Right.
We're covering a lot of ground neurocognitive disorders and CDs, but also those really acute neurological emergencies.
And the pharmacology, too, which is complex, to say the least.
Definitely. It feels like a sobering journey ahead, but a really important one.
It is. And, the sources give us a perfect starting point, a really vivid illustration of just how complex NCD symptoms can be. Think about describing fireworks.
Ah, I know the one you mean, where you can explain the whole experience.
Yeah, you can say, those things, they go up in the sky, make different colors, and go boom.
Yeah.
You articulate the concept perfectly.
But the actual word firework just isn't there. It's completely gone.
That's expressive aphasia right there.
Mhm.
The knowledge, the input, it's still intact.
Mhm.
But the retrieval path, that specific language domain, it's broken.
It shows these disorders don't just wipe the slate clean.
No, not usually. They often shatter the connections, the bridges we use to get to the information.
Okay, so let's unpack this a bit. What's the real line between just getting older and having a clinical NCD? Some decline is normal, right?
Oh, absolutely. Processing speed slows down. Recall might take a beat longer.
Mhm.
That's expected. But NCDs are different. They're defined by a disruption in those 6 core cognitive domains
Right.
that's severe enough to actually impair your functional abilities.
Your activities of daily living, the ADLs. That's the key phrase.
That distinction is really the diagnostic separator.
Mm.
When the decline hits your independence, managing finances, medications, basic self-care, then we're talking about a disorder, not just aging.
And the first domino to fall is usually memory.
Generally, yes. And specifically, it tends to be the short-term storage that goes first.
Which explains that classic pattern we hear about. Someone can vividly remember their wedding day from 50 years ago.
Oh yeah, crystal clear. They're nursing glory days, as one source put it.
But ask them what they had for breakfast.
Poof, gone. Just completely blank.
Why is that? Why does short-term memory get hit so much harder, especially early on?
Well, think about how memories are stored. Those remote long-term memories, they've been consolidated over years, maybe decades. They're wired into large, pretty stable networks across the cortex.
Okay.
Short-term memory, though, relies really heavily on specific structures, like the hippocampus, for that initial encoding and storage.
And those structures are vulnerable.
Very. They're often the first places hit by the pathology in conditions like Alzheimer's. So the ability to form new memories, to log those recent events, fails first.
Makes sense. So after memory, what's next? Language.
Language often follows.
Uh-huh.
We mentioned expressive aphasia, trouble finding words. But the sources also highlight problems with more complex tasks, like signing a check.
Which sounds simple, but involves language and motor skills.
Exactly. The coordination needed is actually staggering. We just take writing our name for granted. But the sources describe people having to literally talk themselves through it.
Like spelling it out loud.
Yes, spelling their own last name, letter by painful letter, just to get the sound translated into a written word on the page. It shows how much processing power those seemingly simple functional skills require.
Wow. Okay, then there's perceptual motor function. This shows up as clumsiness.
Yeah, generalized clumsiness is common. Poor depth perception, getting easily disoriented in familiar spaces. The brain is struggling to mesh what it's seeing and feeling with the motor commands needed to move around safely.
Got it. And social cognition, that seems like a different category.
It often is, or it can appear later, or be more prominent in specific types of NCDs. This is where you see the loss of that social filter.
Mm-hmm.
Saying inappropriate things, acting out in public, maybe a really disturbing lack of empathy for other people's feelings or situations.
Then a really big one. Executive function, organizing, planning.
Absolutely critical. And it's more than just forgetting. The source anecdote about the unpaid HOA fees illustrates this perfectly.
Right. It wasn't just forgetting the bill was due.
No, It was the whole sequence, the inability to even start the process of paying it, to prioritize it, find the checkbook, write the date, figure out the balance, actually mail it, and plan ahead for the next one.
That entire chain of action.
That whole sequence failing, that's the executive function breakdown. It's the planning and execution part.
And the last domain, complex attention.
Right. The inability to juggle multiple things,
Yeah.
to focus when there are distractions.
This sounds a bit like ADHD almost.
It can look very similar. You see abandoned projects everywhere. Someone starts cleaning the kitchen, then gets distracted by a magazine, starts reading it, then spots something else. And the kitchen is completely forgotten.
A decline from their previous ability to focus.
Exactly. Profound inattention.
Mm-hmm.
But it's a loss of a previously established function, which is different from developmental ADHD.
So with all these subtle declines, how do doctors actually catch this early before things get really bad?
Well, there are standardized assessment tools. The Mini-Mental Status Exam, or MMSE, is a common one.
What does that involve?
Clinicians test things like orientation time, place, immediate recall, language fluency, and some complex tasks like spelling the word world backward
Okay.
or counting down from 100 by sevens. They also test recall after a delay, asking you to remember 3 unrelated words like pen, clock, watch, after a few minutes of distraction.
And visually, there's the clock test. I've heard this is quite revealing.
Oh, it provides incredibly clear visual evidence of decline. It's remarkably effective because it taps into spatial reasoning, abstract thinking, and executive function all at once.
What's the actual task?
Simple on the surface. You ask the person to draw a clock face on a blank piece of paper, put in all the numbers, and then draw the hands to show a specific time, like, say, 10 minutes past 11.
And the errors show the problems.
Clearly, you might see someone draw the numbers backward or miss numbers entirely, or they cram all 12 numbers into just one half of the circle.
Wow.
Or sometimes they even draw the hands outside the clock face altogether. It's a powerful visual diagnostic.
Now, that clock test seems pretty definitive, but are there pitfalls? The sources must mention potential false positives, right? Like, what if someone just has really bad eyesight or shaky hands? Could that skew the results?
That's a really critical point, and yes, the sources absolutely emphasize this. The clinician has to rule out simple sensory or motor deficits first. If someone has severe macular degeneration, they might fail because they literally can't see well enough to draw accurately. Or if they have an essential tremor, their hand might shake too much. The failure might be in the execution, not the underlying cognition.
So you need other tests alongside it.
Exactly. That's why you use the verbal and memory parts of the mini-mental assessment too.
Yeah.
You need multiple data points to really isolate the cognitive part of the deficit.
Right, that makes total sense. And this underlying complexity, it probably explains that phenomenon of people faking out in public, doesn't it? They can seem totally fine in a brief chat.
Precisely. And we can even understand the why neurologically. Those routine, automatic social scripts, hi, how are you, fine, thanks, and you?
Mm-hmm.
They're often handled by older, more automated subcortical brain structures.
They don't require much active thought.
Exactly. They don't need novel planning or complex memory retrieval. It's autopilot. The breakdown only becomes obvious when you push beyond that.
When you ask something requiring real thought.
Yes, anything needing that cortical executive function. Genuine problem solving, digging deep for a specific memory sequence, organizing complex information. That's when the NCD becomes exposed.
And we're not talking about a small number of people here. The statistic is, what, nearly 14% of people over 72?
Approximately 13.8% of those aged 72 and older are dealing with some form of NCD. It's a significant public health issue.
Okay, so let's dive into the specific chronic disorders, and we have to start with the biggest one, Alzheimer's disease, AD.
Right, the most prevalent by far. Accounts for what, 60 to 80% of all NCDs?
It's the range, yes. It's huge.
And the stats are pretty stark. 6th leading cause of death in the U.S., risk climbs steeply with age, almost 50% for people over 85.
And interestingly, about 2/3 of those affected are women. We're still trying to fully understand why that gender disparity exists.
And survival, it's limited, average of 8 to 10 years after diagnosis, the sources say. Unfortunately, yes. Now, the underlying physical changes in the brain are really key to understanding AD. Pathologically, you see significant cortical atrophy. The brain literally shrinks,
Which parts are hit hardest?
particularly the parietal and temporal lobes. These are crucial for integrating sensory info, language, memory consolidation.
Yeah.
So their loss is devastating.
And then there are the microscopic hallmarks everyone hears about, plaques and tangles.
Exactly. We need to be specific about both. First, the neuritic plaques, also called amyloid plaques. These are clumps of misfolded amyloid beta protein that build up outside the neurons, in the space between the cells.
Like debris cluttering things up.
Kind of like scar tissue, yeah. They physically get in the way, disrupting the synapse where neurons communicate, blocking proper neurotransmitter exchange.
Okay, so that's outside the cell. What about inside?
Inside the neuron, you find the neurofibrillary tangles. These are made of a protein called tau. Normally, tau helps stabilize the neuron's internal skeleton, its transport system. Think of them like railroad ties keeping the tracks stable. In AD, the tau protein gets altered, hyperphosphorylated misfolds, and clumps together into tangles. This causes the internal tracks, the microtubules, to disintegrate.
So the cell can't transport anything.
Exactly. Nutrients, proteins, energy components. They can't move from the cell body down the axon to the synapse. The neuron basically starves and breaks down from the inside out.
Wow. So it really is a double whammy. Debris blocking communication outside and the internal transport system collapsing inside.
It's a devastating 1-2 punch, which helps explain why the progression is so relentless.
But getting a definitive diagnosis while someone is alive is tricky, right? It's often called a diagnosis of exclusion.
Absolutely. Because the only way to be 100% certain is to examine brain tissue under a microscope, usually at autopsy, though sometimes biopsy. So clinically, diagnosing AD involves ruling out everything else that could be causing similar symptoms.
Like what?
Oh, a whole range. Metabolic problems, severe thyroid issues, major vitamin deficiencies, B12 or thiamine are common culprits. Chronic infections, even severe prolonged stress or depression can mimic dementia.
So you check for all those reversible causes first.
Mandatory. Only when those are eliminated can a clinician confidently assign a probable AD diagnosis.
Genetics obviously play a role, but the sources also talk a lot about lifestyle factors and this interesting tension between heart health and brain health.
Yes, this is a fascinating and tricky area. We have good evidence that things like a healthy diet, regular physical exercise, and keeping your brain active cognitive engagement can lower the risk of AD.
Okay, that makes sense.
But then you hit the cholesterol debate. For heart health, doctors often prescribe statins to lower cholesterol levels systemically.
Right, standard practice for cardiovascular risk.
But the brain needs fat. It's largely made of fat. Cholesterol and phospholipids are essential for building cell membranes, for the myelin sheath that insulates nerve fibers, even for neurotransmitter function.
So the potential conflict is lowering cholesterol aggressively for the heart might inadvertently starve the brain of materials it needs to maintain itself.
That's the concern highlighted in the sources, yeah. It raises a really tough question for doctors treating older adults. How do you balance managing cardiovascular risk without potentially compromising the brain's long-term structural health by depleting necessary lipids?
No easy answer there.
Not at all. But it certainly suggests that ensuring people get enough healthy fats like omega-3s might be particularly important for brain health as we age.
And the sources mention how sometimes a specific event can seem to accelerate the decline. The example of the mother whose vision loss triggered a faster slide was quite powerful.
Very vivid example. She was a lifelong avid reader, reading maybe a book a day, apparently. When macular degeneration caused total blindness, that primary source of intense daily cognitive stimulation was just gone suddenly.
And her decline sped up.
Dramatically, according to the source. Her language and executive function worsened much more rapidly without that constant mental workout from reading. It really underscores how vital it is to find alternative ways to keep the brain engaged, especially when other abilities start to fade.
Okay, let's shift gears now. From those chronic, slow declines like AD to something very different. Delirium. This is acute, right? Sudden confusion.
Yes, and that distinction is absolutely vital. Delirium is not dementia. It's an acute, confusional state, fluctuating, that develops quickly over hours or days.
So NCDs are about memory and executive function failing over time.
Right, whereas delirium is primarily a rapid failure of attention and overall awareness. And the confusion level can swing wildly, even within the same day. Find 1 minute, completely disoriented the next.
What's happening in the brain during delirium? Is it structural damage?
Not typically structural, no.
Yeah.
It's more rooted in a kind of global systemic distress that affects the brain, inflammation, impaired brain metabolism.
Okay.
And crucially, it involves a widespread disruption of neurotransmitter function, a major imbalance, often involving acetylcholine, serotonin, GABA, dopamine, too much excitation maybe, or not enough inhibition. It's a chemical chaos.
And the triggers, they seem really common in hospitals, especially.
Hugely common in institutional settings. Medications are probably the biggest culprits. Narcotics, opioids, benzodiazepines, even some antihistamines in older adults.
What else?
Withdrawal syndromes, especially from alcohol or benzos, those can cause massive brain hyperexcitability. Post-anesthesia effects can linger, particularly in the elderly.
Infections.
Big one. Infections and high fevers. The source anecdote about the son with a 104+ fever. Totally confused, couldn't even find the bathroom in his own house. That perfectly shows how systemic illness can cause acute brain dysfunction.
Are there specific metabolic things to watch for?
Definitely. High ammonia levels, which you often see with liver failure, are notorious for causing confusion. And electrolyte imbalances, especially low sodium levels, hyponatremia, can trigger delirium.
And just being in the hospital environment itself.
Sleep deprivation is a huge factor. Combine that with the stress, the noise, the constant interruptions. It's a perfect storm for an older, vulnerable brain.
Symptoms can vary a lot.
Widely, from someone being really hypoactive, decreased consciousness, barely responsive, all the way to hyperactive states with agitation, aggression, pulling at lines, flailing.
And the treatment approach is totally different from NCDs.
Fundamentally different. Treatment for delirium is strictly supportive care, plus identifying and reversing the underlying cause immediately.
So find the trigger.
Find the trigger. If it's an infection, treat the infection. If it's a medication, stop or change the medication. If it's an electrolyte imbalance, correct it. You cannot treat delirium itself with dementia drugs. It won't work.
And if you don't fix the cause,
The delirium will likely persist, maybe even worsen, and potentially lead to longer-term cognitive problems or permanent damage. Addressing the root cause is everything. #CX. Other key NCDs.
Okay, beyond Alzheimer's and delirium, the sources cover several other important NCDs. Each seems to have its own unique fingerprint.
They really do. Let's talk about NCD due to Parkinson's disease PDs.
We think of Parkinson's mainly for the motor symptoms, the tremor, the rigidity.
And those define it, yes. But cognitive impairment is actually very common in PD, and it tends to worsen slowly over time. The core pathology involves Lewy bodies.
Lewy bodies. Those are abnormal protein clumps, right? Like in AD, but different proteins.
Similar concept, different protein, alpha-synuclein in this case. These Lewy bodies accumulate, particularly in a brain area called the substantia nigra.
Which is where dopamine is produced, hence the motor problems.
Exactly. The Lewy bodies cause the degeneration of those dopamine-producing cells. But, and this is key, the sources emphasize that the damage isn't limited to dopamine. It also affects cells producing other neurotransmitters, like serotonin and norepinephrine.
And that contributes to the non-motor symptoms.
Directly. Things like slowed thinking, significant problems with executive function, and unfortunately, high rates of depression and sometimes aggression are linked to these broader neurotransmitter changes.
And there's a crucial medication warning here for PD patients with cognitive issues or psychosis.
Absolutely critical. Avoid traditional antipsychotic medications. Most antipsychotics work by blocking dopamine receptors. In someone with PD, that will dramatically worsen their motor symptoms, increase rigidity, slow them down even more. It's a dangerous interaction.
Got it. Okay, next up, frontotemporal degeneration, FTD, sometimes called Pick's disease.
That's right. As the name suggests, this involves progressive deterioration specifically of the frontal and temporal lobes of the brain.
What's distinctive about FTD?
A couple of things stand out. One is the age of onset. It often hits earlier than AD, sometimes in people's 40s or 50s. The other is a strong familial link. Maybe 30 to 50% of cases have a family history.
And because it hits the frontal lobes first, the initial symptoms are different from AD's memory focus.
Exactly. The symptoms tend to be primarily behavioral or language-based, at least initially. Memory might be relatively preserved early on.
The sources mention two main presentations.
Right. The behavioral variant's more common. The frontal lobe is our personality center, inhibition control. So as it deteriorates, you see major personality changes. Inappropriate social behavior, saying shocking things, complete loss of empathy, poor judgment, impulsivity.
And the other variant?
The language variant, sometimes called primary progressive aphasia. This directly attacks the language centers in the temporal and frontal lobes. It impairs the ability to either produce speech coherently or to understand spoken language, or both.
The sources cited actor Bruce Willis as an example of this, right? His retirement was due to aphasia.
Yes, his primary symptom, as reported, was this specific type of progressive difficulty with speech production, fitting the language variant of FTD. It's devastating.
Okay, shifting focus to blood flow issues, vascular NCD, or multi-infarct dementia.
Right. This accounts for maybe 10% or so of dementias, and it's essentially caused by damage from poor blood supply.
Little strokes.
Exactly. Multiple small ischemic events, tiny clots blocking tiny vessels, or sometimes small hemorrhagic events, little bleeds. Over time, the cumulative damage from these mini-strokes destroys enough brain tissue to cause cognitive decline.
And the risk factors are basically stroke risk factors.
Identical. High blood pressure is a huge one. Smoking, high cholesterol, diabetes, underlying heart disease, anything that damages blood vessels or affects blood flow increases the risk.
Then we have brain damage from physical force, NCD due to traumatic brain injury, TBI, and the related condition, CTE.
CTE, chronic traumatic encephalopathy. This is the one strongly linked to repetitive head trauma. It's not necessarily one single massive injury, but rather the cumulative effect of repeated blows, even seemingly mild concussions or subconcussive hits over years.
Like in sports.
Exactly. Pathologically, CTE looks somewhat similar to Alzheimer's in one respect. The trauma causes tau protein, that same protein involved in AD tangles, to misfold and accumulate, forming neurofibrillary tangles that disrupt brain function.
Which sports are most implicated?
The sources are very clear. American football is high on the list due to the nature of impacts. Boxing, obviously. And interestingly, soccer is also consistently mentioned,
Soccer? Why?
primarily because of heading the ball repeatedly over many years and also the risk of head-to-head collisions. Both deliver those repetitive subconcussive impacts that seem to drive CTE pathology.
Right. Okay, one more specific NCD, Wernicke-Korsakoff syndrome. This one's linked to alcohol.
Strongly associated with chronic heavy alcohol use. The ethanol itself is toxic to brain cells and can cause cortical atrophy, particularly affecting the cerebellum, which controls coordination. It can also lead to hydrocephalus, excess fluid buildup.
But the core mechanism isn't just the alcohol toxicity, is it?
No, the primary driver is actually a severe deficiency of vitamin B1, which is thiamine.
Why does alcohol cause that deficiency?
Chronic alcohol use damages the stomach lining and impairs the absorption of nutrients, including thiamine. And thiamine is absolutely critical for brain metabolism. It's a necessary cofactor for enzymes involved in converting glucose into energy at ADP within brain cells.
So no thiamine, no energy.
Essentially, the brain cells are starved of their primary fuel, even if glucose is available. This leads to cell damage and death, particularly in areas crucial for memory, like the thalamus and mammillary bodies. That's what causes the profound memory loss, Korsakoff psychosis, and confusion, Wernicke encephalopathy.
Which is why giving thiamine, often intravenously in that yellow banana bag cocktail, is so crucial for these patients in the hospital.
Absolutely mandatory.
Yeah.
You have to replenish their thiamine stores immediately to prevent further irreversible brain damage.
Okay, let's talk about the medications used for these chronic NCDs. The sources seem quite clear about setting expectations here.
Yes, and this is probably the most critical point about the pharmacology. Current medications are not cures. They don't reverse the damage, they don't restore lost memories.
So what do they do?
At best, they can slow down the progression of symptoms for a period of time in some people. They might offer a window of slightly improved function or stability.
Which means the overall care goals have to be realistic.
Absolutely. The focus remains on supportive care, ensuring safety, providing appropriate mental stimulation, managing behavioral symptoms, and crucially, supporting the caregivers. Respite care is essential.
The sources really hammered home the issue of caregiver burnout. It sounds universal. Did they offer specific insights on what kind of support actually helps caregivers the most, beyond just, say, adult daycare?
Yeah, they highlighted the importance of behavioral support systems, not just for the caregiver, but for the patient, too. While medications for agitation can help, the most effective respite often comes from structured behavioral therapies for the patient.
How does that help the caregiver?
By training the patient in simple, predictable routines, it can help reduce challenging behaviors like agitation or wandering. This predictability makes the patient's care less chaotic and stressful.
Ah, I see. So the caregiver feels more confident stepping away for a break if the situation feels more stable and less prone to crisis.
Exactly. That reduction in unpredictability is often what provides the most genuine, sustainable respite for the person providing care day in and day out. Hashtag tag tag A, Alzheimer's medications.
Okay, let's look at AD meds specifically. The first big class targets acetylcholine, right? The acetylcholinesterase inhibitors.
Correct. Acetylcholine is a key neurotransmitter for memory and learning, and levels are depleted in AD. The enzyme acetylcholinesterase, ACE, is what normally breaks down acetylcholine in the synapse after it's done its job.
So these drugs block that enzyme.
Exactly. Drugs like Donepezil, brand name Aricept, Rivastigmine, Exelon, and galantamine, they inhibit ACE. By blocking the breakdown enzyme, they allow the reduced amount of acetylcholine that is available to hang around in the synapse longer and have more effect.
Trying to boost the signal, basically.
Trying to boost the signal, yes. This can lead to modest temporary improvements in cognitive function or slow the decline for a while in some patients.
Rivastigmine, Exelon, often seems to be a first choice, and the delivery method matters.
Yes, rivastigmine is frequently used first line, partly because it's available as a transdermal patch.
Ah, that helps with taking the pills.
Hugely. Think about someone already struggling with memory and executive function. Remembering to take a pill multiple times a day is a major challenge. The patch is just once daily application.
And it bypasses the stomach.
Big advantage. Because the major downside, the main side effects of all the ACE inhibitors are gastrointestinal. Nausea, vomiting, diarrhea, stomach cramps that can be really significant.
Oh.
There's also a risk of GI bleeding. The patch delivers the drug through the skin, reducing those GI issues somewhat.
So you have to start these low and go slow.
Absolutely. You have to titrate the dose up very gradually, often over several weeks, to help the patient tolerate the GI side effects. Rapid increases are usually not well tolerated.
Any other major warnings?
Yes, they should be used with caution or are contraindicated in patients with significant underlying liver disease, as they can be tough on the liver.
Okay. Then for more moderate to severe AD, another class often gets added. NMDA receptor antagonists. Memantine. Brand name Namenda.
Right. Memantine works on a different neurotransmitter system, glutamate. Glutamate is the main excitatory neurotransmitter in the brain.
And too much excitation is bad.
In conditions like AD, it's thought that damaged neurons might be overstimulated by glutamate, which can actually be toxic to them, a concept called excitotoxicity. Memantine helps to block this excessive glutamate activity, offering a neuroprotective effect.
How does it compare side effect-wise?
Generally, memantine is better tolerated than the ACE inhibitors, fewer severe GI problems. The side effects tend to be more neurological things like dizziness, headache, sometimes confusion or agitation, but often milder. #B Parkinson's medications.
All right, switching to Parkinson's, the goal here is different, right? It's about rebalancing dopamine and acetylcholine.
Exactly. Parkinson's is fundamentally a disease of dopamine deficiency. So the pharmacology aims to either boost dopamine levels or effects, or sometimes decrease the relative overactivity of acetylcholine.
So, starting with the anticholinergics like benztropine, what do they target?
These drugs primarily help with the muscle rigidity and, to some extent, the tremor in PD. They work by decreasing the effects of acetylcholine. By dampening acetylcholine, the remaining dopamine has a relatively stronger effect, helping to smooth out movement.
But they don't help all symptoms.
No. Importantly, they have very little effect on the bradykinesia, the slowness of movement, which is often the most disabling symptom for people with PD.
So the real cornerstone of PD treatment is usually the dopaminergic medication, the combination of carbidopa and levodopa. Sinemet is a common brand name.
Absolutely. Levodopa is the gold standard. Levodopa is a precursor molecule that the brain can convert into dopamine.
So why not just give levodopa? Why the carbidopa combination?
Well, if you just take levodopa by itself, most of it gets broken down by enzymes in the bloodstream before it even reaches the brain. Maybe only 1% actually crosses the blood-brain barrier.
So carbidopa acts like a bodyguard.
That's a great analogy. Carbidopa inhibits one of the main enzymes, dopa decarboxylase, that breaks down levodopa in the periphery, outside the brain. By blocking that breakdown, much more levodopa is able to get into the brain where it's needed.
And this also helps with side effects.
Dramatically. Taking straight levodopa causes massive nausea and vomiting, and can even trigger psychotic symptoms because of all the dopamine being produced outside the brain. The combination with carbidopa significantly reduces these peripheral side effects.
But the combo still has side effects.
Oh, yes. Things like orthostatic hypotension dizziness when standing up are common. Cardiac dysrhythmias can occur. And motor complications like dyskinesias, involuntary movements, can develop over time.
And the sources must touch on the wearing off effect. That sounds like a major challenge.
It's a huge clinical challenge, especially as the disease progresses. Initially, a dose of carbidopa-levodopa might provide smooth symptom control for, say, 4 or 5 hours. But over years, that duration of benefit shrinks. Maybe it only lasts 2 or 3 hours. So the patient starts experiencing wearing off their symptoms return before the next dose is due.
And those on-off fluctuations.
Right. They might swing between periods of being relatively mobile and functional, on time, and periods of severe stiffness, slowness, and tremor, off time. Managing these fluctuations requires very careful, often complex, adjustments to medication timing and dosage. It can become incredibly difficult.
Makes adherence really tough. Okay, what about MAO-B inhibitors, like selegiline or rasagiline?
These are often used early in PD, sometimes even before starting levodopa. MAOB is another enzyme in the brain that breaks down dopamine.
So these inhibit that enzyme.
Exactly. By inhibiting MAOB, they slow the breakdown of the dopamine that's still being produced, making it last longer. This can provide mild symptomatic benefit and often delays the need to start levodopa, maybe for 6 months to a year.
But there's a critical dietary restriction with these.
Yes, absolutely crucial. Patients taking MAOB inhibitors must avoid foods high in tyramine.
Why? What's tyramine in?
Tyramine is found in things like aged cheeses, cured meats, like salami, pepperoni, fermented foods, sauerkraut, soy sauce, red wine, certain beers, and even overripe bananas.
And the interaction is dangerous.
Potentially life-threatening. Normally, MAO enzymes in the gut and liver break down tyramine from food. But if you're inhibiting MAO, even the relatively selective MAOB inhibitors can affect MAOA at higher doses or in some individuals, tyramine gets absorbed into the bloodstream.
And what does tyramine do?
It causes a massive release of norepinephrine, leading to severe sudden vasoconstriction and a potentially catastrophic spike in blood pressure, a hypertensive crisis. Headaches, sweating, palpitations, it can lead to stroke or death. Strict dietary adherence is non-negotiable.
Wow. Okay, finally for PDE, what about the psychosis hallucinations, delusions that can happen? Up to 50% of patients?
Yes, Parkinson's disease psychosis is a significant problem, especially in later stages. And as we said, you can't use typical antipsychotics because they block dopamine and worsen motor symptoms.
So there are specific drugs.
Yes, there are newer, atypical antipsychotics developed specifically for this, like pimavanserin, Nuplazid. These work differently, targeting specific serotonin receptors thought to be involved in psychosis, with minimal impact on the dopamine pathways needed for motor control.
Okay, we've covered the slow burns of chronic NCDs. Now let's shift to the flash fires, the acute brain crises. We're talking minutes mattering, right? Starting with lack of oxygen and rising pressure.
Absolutely. We need to nail down two terms first. Hypoxia, which is a shortage of oxygen supply,
Okay.
and ischemia, which is a problem with blood flow. Inadequate perfusion. Both ultimately starve the brain of oxygen and, critically, glucose. Without those, you can't make ATP, the cell's energy currency.
Let's take the most extreme case, global ischemia, like during a cardiac arrest when the heart stops completely.
Right.
What happens in the brain second by second?
It's terrifyingly fast. Within just seconds of blood flow ceasing globally, consciousness is lost. The brain's stored ATP is basically gone within about 4 to 5 minutes.
And when the ATP runs out,
Everything grinds to a halt. Aerobic metabolism stops. And crucially, the ion pumps in the cell membranes fail, especially the sodium-potassium pump, which uses a ton of energy.
what happens when that pump fails?
Sodium, which is normally pumped out of the cell, rushes in. Water follows the sodium, causing the cell to swell rapidly. That's cytotoxic edema.
But the swelling isn't the killer blow, is it?
Not directly. The truly catastrophic event is the massive influx of calcium into the cell, which also happens when the pumps fail and membranes depolarize.
Why is calcium so bad?
Excess intracellular calcium acts like a wrecking ball. It activates destructive enzymes, proteases that chew up proteins, phospholipases that destroy cell membranes. It essentially triggers the cell to self-destruct through processes like necrosis and apoptosis.
And meanwhile, the cell is trying to survive without oxygen.
Right, it desperately switches to anaerobic metabolism. But that's inefficient and produces lactic acid as a byproduct.
Yeah.
Lactic acid builds up, the cell environment becomes acidic, acidosis, and that just accelerates the destruction.
So if someone survives cardiac arrest, the goal is to minimize this secondary damage.
Exactly. Treatment focuses on damage control by reducing the brain's metabolic demands while it tries to recover. That's why induced hypothermia, keeping the patient cool, is often used.
Slows everything down.
Slows down all those destructive chemical reactions. You also need meticulous supportive care, maintaining adequate blood pressure, hemodynamic support, ensuring oxygenation, respiratory support, and very tight control of blood glucose levels. High or low glucose can worsen brain injury, usually aiming for around 140 milli-GDL.
Okay, so that's energy failure. What about mechanical failure? Increased intracranial pressure, ICP. The skull doesn't stretch.
Exactly. The skull is a rigid box. Inside you have brain tissue, blood, and cerebrospinal fluid, CSF. If any of those increase significantly too much CSF, bleeding from a hemorrhage, swelling from edema, or a growing mass like a tumor, the pressure inside that box has to rise.
and the very first sign something is wrong.
The earliest and most reliable clinical sign of rising ICP, according to the sources, is a decreased level of consciousness, LOC.
Even subtle changes.
Yes, it might just be slight drowsiness, confusion, restlessness, or disorientation. Any change for the patient's baseline LOC is a red flag.
What follows LOC changes?
Pupil changes are often next. One pupil might become dilated, larger, and stop reacting normally to light. This often happens on the same side as the pressure problem.
And then posturing.
Yes, if the pressure continues to rise and starts compressing the brainstem. First, you might see decorticate posturing.
Describe that.
Arms are flexed or bent inward towards the chest, fists clenched, legs extended. This indicates damage above the midbrain level, maybe to the cerebral hemispheres or internal capsule.
And the worst sign?
Decerebrate posturing. Here, the arms are rigidly extended straight out, wrists flexed outward, legs extended. This is more ominous because it implies damage at or below the level of the midbrain, affecting the brainstem itself.
If pressure keeps building, the body tries a last-ditch effort, the Cushing reflex.
Yes, Cushing's reflex or Cushing's triad. This is a physiological response triggered by severe brainstem ischemia. It's a very late and dangerous sign.
What are the components of the triad?
It's characterized by three specific things. 1, severe hypertension, very high blood pressure. 2, bradycardia, a slow heart rate, paradoxically. And 3, irregular respirations, like Cheyne-Stokes breathing. You also often see a widening pulse pressure. The gap between the systolic and diastolic numbers increases.
Seeing that triad means?
It means brain herniation, where parts of the brain are being squeezed out of their normal compartments, is likely imminent or already happening. It's a dire emergency.
Pressure can also come from brain swelling itself, cerebral edema, 2 main types.
Right. We mentioned cytotoxic edema already. That's when the cells themselves swell and burst due to influx of sodium and water, typically seen in ischemia, or maybe water intoxication if someone drinks way too much water too fast, can lead to stupor or coma.
And the other type?
The more common type is vasogenic edema. This is a problem with the blood-brain barrier.
The barrier becomes leaky.
Exactly. The normally tight junctions between the cells lining the brain's blood vessels break down. This allows fluid, proteins, and other large molecules to leak out of the blood vessels and into the surrounding brain tissue.
What causes that leakiness?
Things like brain tumors, hemorrhage, infections, or localized tissue ischemia can all disrupt the blood-brain barrier and cause vasogenic edema. The leaked fluid increases tissue volume and pressure.
How do you treat edema?
Depends on the cause and type. For localized vasogenic edema around a tumor, high-dose glucocorticoids, steroids like dexamethasone, can help stabilize the blood-brain barrier. For more acute generalized edema, like after an injury, osmotic therapy is used.
Like mannitol.
Mannitol is the classic osmotic agent. It's given intravenously, stays in the bloodstream, and creates an osmotic gradient that literally pulls excess water out of the brain tissue and back into the blood vessels to be excreted by the kidneys. It dehydrates the brain.
One last pressure problem, hydrocephalus. Too much CSF.
Yes, hydrocephalus means an enlarged CSF compartment. It can happen because the CSF isn't being reabsorbed properly back into the bloodstream, communicating hydrocephalus, or because there's a physical blockage somewhere in the CSF pathways, preventing it from circulating normally, non-communicating hydrocephalus.
The non-communicating type is often seen in kids.
Yes, often congenital, due to blockages in the narrow passages connecting the brain's ventricles. The treatment for chronic hydrocephalus usually involves surgically inserting a shunt.
A drain tube.
Essentially, yes. A tube that diverts the excess CSF from the brain's ventricles to another body cavity where it can be absorbed, most commonly the peritoneal cavity in the abdomen.
Okay, let's move specifically to injuries caused by external force or blood vessel problems in the head, starting with traumatic brain injuries, TBIs. The idea of brain bruises or contusions seems key.
Yes, and understanding the mechanics helps. A coup injury is the bruise directly underneath the point of impact. Your head hits the windshield, the brain hit the inside of the skull right there. That's the coup.
But then there's the rebound.
Exactly. The contra-coup injury. The brain recoils from the initial impact and slams into the opposite side of the skull. So you get a second bruise on the side, away from the direct blow.
Common in car crashes?
Very common in acceleration-deceleration injuries, like car accidents, falls, or shaken baby syndrome. You can have both coup and contra-coup injuries from a single impact event.
Beyond bruising, we worry about bleeding hematomas. Location is everything here.
Location defines the type and often the urgency. Let's start with epidural hematoma.
Where is that?
Epi means above, so it's between the skull bone and the duramater, the tough outer lining of the brain.
And these are usually arterial. Fast.
Usually, often caused by a fracture of the temporal bone, tearing the middle meningeal artery. Because it's arterial bleeding, it's typically rapid and builds pressure quickly.
What's the classic presentation?
Often, a brief loss of consciousness at the time of injury, followed by a lucid interval where the person seems okay, maybe just has a headache, but then as the hematoma expands rapidly, they crash neurologically. LOC declines fast.
Specific signs.
You often see ipsilateral pupil dilation. The pupil on the same side as the bleed gets large and fixed, and contralateral hemiparesis, meaning weakness or paralysis on the opposite side of the body.
Prognosis.
Can be very good if it's diagnosed and surgically evacuated extremely quickly. Time is critical to relieve the pressure before irreversible brain damage occurs.
Okay, then subdural hematoma. Where's this one?
Sub means below, so this is between the
Yeah.
duramater and the next layer down, the arachnoid mater,
Yeah.
or sometimes listed as the subarachnoid space in practical terms.
And these are venous. Slower.
Typically, yes. Usually caused by tearing of the bridging veins that cross that space, often due to shearing forces during head movement, especially in older adults whose brains may have shrunk slightly,
Yeah.
putting tension on those veins.
And this explains why they're sometimes missed initially.
Exactly. Because the bleeding is venous and lower pressure, it can be slow and insidious. An elderly person might have a seemingly minor fall, feel okay afterward, but then days or even weeks later, they gradually become confused, drowsy, or develop neurological symptoms as the slow bleed accumulates.
The delayed presentation makes them notorious.
Very much so. Always needs to be considered in an older person with a recent fall and new confusion.
And the third type, intracerebral hematoma.
Intra means within. This is bleeding directly into the brain tissue itself.
Causes.
Can be caused by severe head injury, where forces disrupt vessels within the brain parenchyma. Also linked to hypertension, causing small vessels to rupture, or sometimes related to bleeding disorders or substance abuse. Often occurs in the frontal or temporal lobes.
Prognosis here.
Generally poorer than epidural or even subdural, because the blood itself is directly damaging and irritating the delicate brain tissue, not just causing pressure from the outside.
Okay, one crucial point about penetrating injuries. Gunshot wounds, stabbings, if the object is still there.
Leave it in place. Absolutely critical pre-hospital rule. Do not pull it out,
Why not?
because the object itself might be tamponating, plugging a severely injured blood vessel. Removing it could unleash massive, uncontrollable hemorrhage. It also risks causing further tearing and damage as it's withdrawn. Stabilize the object, transport the patient, and let surgeons remove it in a controlled operating room environment.
Got it. Okay, shifting to strokes, cerebrovascular disease, we know the big risk factors. Hypertension, smoking, age, high cholesterol, oral contraceptives for women, but one really stands out in the sources, atrial fibrillation.
Yes, AFib is a major risk factor specifically for embolic strokes.
Explain that link.
In AFib, the upper chambers of the heart, the atria, quiver chaotically instead of beating effectively. This allows blood to become stagnant and pool, particularly in a little pouch called the left atrial appendage. Stagnant blood forms clots.
And those clots travel.
Exactly. A piece of clot can break off, travel through the bloodstream, and lodge in an artery in the brain, blocking blood flow and causing an ischemic stroke. That's why anticoagulation, blood thinners, is so important for most people with AFib.
Most strokes, about 75%, are ischemic, caused by clots or plaque blockage. The key concept here for treatment is the penumbra.
Absolutely central. The penumbra is the region of brain tissue surrounding the core infarct, the area that's already dead due to lack of blood flow.
But the penumbra isn't dead yet.
Not yet. It's minimally perfused, struggling, dying, but potentially salvageable if blood flow can be restored quickly enough. The whole goal of acute ischemic stroke treatment is to save the penumbra.
Which is why time is brain.
Precisely. Every minute that goes by, more of that penumbral tissue dies and becomes part of the irreversible core infarct.
This brings us to TIA's, transient ischemic attacks. People sometimes call them mini strokes, but they're more like warning shots.
Critical warning shots. A TIA is a temporary episode of neurological dysfunction caused by brief ischemia, but the symptoms resolve completely, usually within minutes to an hour, because blood flow is restored spontaneously.
But the danger isn't over.
Far from it. Having a TIA dramatically increases your risk of having a full disabling stroke soon after. The stats are alarming. 10–15% of TIA patients will have a major stroke within 3 months. and almost half of those occur within the first 48 hours after the TIA.
So a TIA is a true medical emergency requiring immediate workup.
Absolutely. Don't ignore those symptoms just because they went away.
Okay, the other 25% or so of strokes are hemorrhagic bleeding strokes caused
What's
by...
usually a ruptured blood vessel, often due to uncontrolled high blood pressure weakening an artery wall over time, or the rupture of a cerebral aneurysm, a weak bulge in an artery wall.
These are generally more dangerous.
Often very dangerous, yes. The bleeding itself causes damage, and the blood rapidly increases intracranial pressure. They often occur spontaneously.
Is there a hallmark symptom?
The classic, though not always present, symptom is the thunderclap headache. Patients describe it as an incredibly abrupt, severe headache, reaching maximum intensity within seconds or a minute, often the worst headache of my life.
Any other signs?
Vomiting is common, sometimes loss of consciousness. Interestingly, the sources note that some people might experience unusual milder headaches for days or weeks before a major rupture, possibly due to small leaks or stretching of the aneurysm wall.
And AV malformations, what are those?
Arteriovenous malformations. These are congenital tangles of abnormal blood vessels where high-pressure arteries connect directly to low-pressure veins without the usual buffer of capillaries in between. This high-flow, high-pressure connection puts immense stress on the thin-walled veins, making them prone to rupture and causing a hemorrhagic stroke, often in younger people.
Whether it's clot or bleed, recognizing stroke symptoms fast is key. The BE fast mnemonic helps here.
Yes, it's a great tool. B for balance, sudden loss of balance or coordination. E for eye, sudden vision changes, double vision, or loss of vision in one eye. F for facial drooping or numbness, usually on one side. Ask the person to smile. Is it uneven? A for arm or leg, sudden weakness or numbness in one arm or leg. Ask them to raise both arms. Does one drift downward? S for speech, slurred speech, difficulty speaking, or trouble understanding speech. Ask them to repeat a simple sentence.
T.
T is for time. Time to call 911 or your local emergency number immediately if you see any of these signs. Note the time the symptoms first started.
Because that last known normal time is critical for treatment decisions.
Absolutely critical. For ischemic strokes, there's a time window, often 3 to 4.5 hours, sometimes longer in specific cases, during which clot-busting drugs, thrombolytics like TPA, tissue plasminogen activator, can be given to dissolve the clot and restore blood flow.
But only if you know it's an ischemic stroke, not hemorrhagic.
Correct. Giving TPA to someone with a hemorrhagic stroke would be disastrous. It would worsen the bleeding. That's why a CT scan of the head is the first thing done in the ER to distinguish between ischemic and hemorrhagic stroke.
And treatment for hemorrhagic is different.
Completely different. Focus is on stopping the bleeding, maybe lowering blood pressure aggressively, potentially neurosurgery, to clip or coil an aneurysm, or evacuate a large hematoma.
Okay, final section. Moving down from the head to the spine and back, this area seems to mix chronic, nagging problems with sudden, potentially catastrophic injuries.
That's a good summary. You have a lot of common degenerative mechanical issues, things like subluxation, where vertebrae slip slightly out of alignment relative to each other.
And spinal stenosis.
Stenosis just means narrowing. So spinal stenosis is a narrowing of the spinal canal, the space where the spinal cord runs. This can compress the cord or nerve roots, often requires surgery like a laminectomy, to physically create more space.
And the classic herniated disc.
Very common. The soft, jelly-like center of an intervertebral disc pushes out through a tear in the tougher outer layer, and that bulging material can press directly on the spinal cord or, more commonly, on the nerve roots branching off the cord.
Causing pain down the leg. Sciatica?
Exactly. That pressure on the nerve root causes peripheral nervous system symptoms. Pain, numbness, tingling, paresthesias that radiate along the path of that nerve, often down the buttock and leg.
How are herniated discs usually treated?
Initial treatment is typically conservative. Anti-inflammatory medications like NSAIDs or sometimes oral steroids, physical therapy to strengthen supporting muscles and improve mechanics, maybe epidural steroid injections to reduce inflammation around the nerve root. Surgeries is usually reserved for persistent, severe symptoms or significant neurological deficits.
But some back pain situations are true emergencies.
Absolutely. Red flags that require immediate evaluation. One is a history of significant trauma, major fall, a car accident, maybe a farm or industrial accident. You have to assume a spinal fracture until proven otherwise.
Second red flag.
Signs of infection or sepsis, especially in high-risk patients like IV drug users or those who are immunocompromised. Back pain with fever, chills, or unexplained weight loss could indicate a spinal epidural abscess pus collecting around the spinal cord. That needs urgent drainage.
And the third, really critical emergency, cauda equina syndrome.
This is a must-not-miss diagnosis. The cauda equina, horse's tail, is the bundle of nerve roots at the very bottom of the spinal cord. If something, usually a large herniated disc, tumor, or trauma, compresses this bundle severely,
What happens?
the defining symptoms are sudden, often severe low back pain combined with new onset of bowel or bladder dysfunction, typically urinary retention, can't pee, or incontinence, loss of control, and or fecal incontinence. May also have saddle anesthesia, numbness in the groin area.
And this requires?
Immediate surgical decompression.
Mm.
It's a ticking clock to relieve the pressure on those nerves before permanent paralysis and loss of bowel bladder function occurs. True surgical emergency.
Okay, now for direct spinal cord injuries, SCIs, caused by?
Usually extreme forces on the spine. Hyperflexion, head forwards sharply forward. Hyperextension, head forwards sharply backward. Excessive rotation or axial compression.
Axial compression, like diving into a shallow pool.
Exactly. That's the classic mechanism. Landing headfirst drives the vertebrae together vertically, often causing burst fractures that can severely damage the cord.
What happens immediately after a significant SCI?
The patient typically enters a state of spinal shock. This is an immediate temporary loss of all spinal cord function, motor, sensory, reflex activity, and autonomic control below the level of the injury.
So complete paralysis and numbness below the injury.
Yes, initially, flaccid paralysis, loss of all sensation, loss of reflexes, and loss of bowel and bladder tone. This spinal shock phase can last hours to weeks.
The sources mentioned a specific complication in men during spinal shock.
Yes, priapism, a persistent, often painful erection unrelated to sexual stimulation. It occurs due to the disruption of autonomic nerve signals controlling blood flow to the penis. While it might seem secondary, it indicates profound autonomic dysregulation and needs management.
Okay, spinal shock is temporary loss of function. But the most dangerous long-term complication for people with higher-level SCIs, T6 or above, seems to be autonomic dysreflexia, AD. This is flagged as a neurological emergency.
It absolutely is, potentially life-threatening. AD is a pathological overreaction of the autonomic nervous system that occurs after spinal shock is resolved in response to a stimulus below the level of the spinal cord injury.
A stimulus the person can't consciously feel.
Usually, yes,
Ah,
because sensation is lost below the injury level. The most common trigger by far is a full bladder, urinary retention. Other triggers include a blocked catheter, constipation or needing to defecate, tight clothing, a pressure sore, even an ingrown toenail. Anything noxious below the lesion.
so what happens physiologically? Why is it so dangerous?
Okay, the noxious stimulus sends signals up the spinal cord, but they get blocked at the level of the T6 or higher injury. This triggers a massive, uncontrolled sympathetic nervous system response below the level of the lesion. Widespread vasoconstriction below the injury level. This shoots the blood pressure sky high, severe sudden hypertension.
Okay, BP is soaring. What does the brain do?
The brain detects this dangerous hypertension via baroreceptors in the neck and aorta. It tries to compensate by sending signals down the intact vagus nerve, part of the parasympathetic system, to slow the heart rate, causing bradycardia. It also tries to cause vasodilation, widening of blood vessels, to lower pressure.
But the signal can't get past the injury.
Exactly. The parasympathetic signals to vasodilate can only reach the parts of the body above the level of the spinal cord lesion.
So you get this dangerous mismatch.
Precisely. You have severe hypertension raging below the injury, bradycardia trying to compensate, and vasodilation, causing flushing and sweating, only occurring above the level of injury.
What are the key symptoms the person or caregiver would notice?
The most common is a sudden pounding headache due to the high BP, profuse sweating and flushed skin above the level of the injury, goosebumps below the level of injury, nasal congestion, blurred vision, anxiety.
And the intervention has to be immediate.
Immediate. The primary goal is to find and remove that noxious stimulus triggering the whole cascade.
Check the bladder first.
Always first. Check for a full bladder, drain it if necessary, check for kinks in the catheter tubing. If it's not the bladder, check for bowel impaction, look for tight clothing or constricting devices, check the skin for pressure areas.
Because if you don't stop the stimulus,
The extremely high blood pressure can lead to seizures, stroke, cerebral hemorrhage, retinal hemorrhage, loss of consciousness, and even death. Autonomic dysreflexia is a true medical emergency requiring rapid identification and intervention. #outro.
wow, okay. We have covered an incredible amount of ground, from the microscopic world of protein tangles and plaques causing slow decline in NCDs,
Right, like in Alzheimer's or CTE?
all the way to the macroscopic, immediate crises of pressure buildup, bleeds, clots, and autonomic failure in acute injuries and strokes. It really maps out the brain's vulnerability from multiple angles.
It does. And a clear theme emerges from the sources. Our treatment options are often limited. For the chronic conditions, it's mostly about slowing things down, supporting function, managing symptoms.
And for the acute crises, it's all about immediate, often aggressive intervention, clot busters, surgery, cooling the brain, relieving pressure, just trying to stop the cascade of damage as quickly as possible.
The underlying connection seems to be the brain's extreme sensitivity. Anything that disrupts its energy supply, its blood flow, its delicate chemical balance, or its structural integrity can have devastating consequences, whether slow or fast.
So for you, the listener, what's takeaways here? I think one is understanding that NCD isn't just forgetfulness. It's that loss of functional independence. Recognizing that change is key.
Absolutely. And knowing those acute warning signs is crucial. BE fast for stroke. Recognizing the sudden confusion of delirium is different from dementia. Understanding the specific symptoms of autonomic dysreflexia if you care for someone with an SCI. That knowledge is protective.
Which brings us to our final provocative thought, drawing everything together. If you look across this whole spectrum, Alzheimer's, delirium, Parkinson's, even TBI and CTE, common threads keep appearing. Chronic inflammation, imbalances in key neurotransmitters like acetylcholine, dopamine, serotonin, problems clearing out cellular debris or misfolded proteins.
Yeah, those themes recur again and again.
So the question to leave you with is this. Given these shared underlying vulnerabilities, what fundamental aspect of basic brain maintenance, something crucial for energy, cleanup, or chemical balance, might we be neglecting most in our modern daily lives that could be increasing our collective risk across this entire wide range of devastating neurological disorders?
Something definitely worth pondering long after this deep dive is over.